time we discussed the finer details of verbal and non-verbal communication. And I tried to put them in 5 essential skills that I think if each one of us practice with our patients and with our fellow colleagues, we can definitely enhance the experience for others and for ourselves also. So I would request you to make note of these 5 skills, because I expect you will keep them in your apron, you will keep them in your pocket, and you'll take them with you, everywhere where you go interacting with your patients and your fellow colleagues. So the first skill that I want you to make note of is building rapport. If I may ask you, what is building rapport?
I didn't get it.
Am I audible?
Yeah.
I'm sorry.
Dr. Lata has raised her hand. So Dr. Lata, please go ahead.
That is creating a connection with the patient, understanding them so that it becomes easier to get a proper history.
Wonderful. That's a very good understanding. Any other addition to what Dr. Lata has explained? Anyone who would like to? It is creating, absolutely, it is creating familiarity. Thank you for adding that point. Excellent. Anything else that you want to add to the
confidence? You have to be receptive.
Confidence, then
receptive to their history.
To get their history, that's what you're saying, Dr. Mukundan?
Receptive. You have to be very receptive, and we should listen to their history properly.
Wonderful. Wonderful. Excellent. Excellent. So is it only for the patient or for us also?
Yes.
No, from both sides.
I would say it's a mutual trust, building of a mutual trust so that they feel like opening.
Absolutely. So I think one idea that we think that building rapport is for the patient is half truth. Actually, it's for both the parties. Even we need to become comfortable with the patient. So it's a good way to start with. Second is, how much time do you think it should take to build rapport? How much time? Any
Less
guess?
than a minute.
1 minute.
Sorry,
Less than
how
a
many
minute.
minutes?
1 minute.
Less than a minute. How many of you agree with Dr. Paul? Dr. Paul says less than a minute. And Dr. Rafiq also says few seconds. Okay. What do others say? Dr. Harimon says what? Dr. Harimon, you wish to say, add something?
I don't
1
think,
minute. Okay.
Yeah, I don't think there's any time limit there. It depends upon how quickly you establish the rapport, the same word I would use. It can be quite fast.
Wonderful.
It is the sincerity that you show to the patient, and the patient accepts you. And you
Absolutely.
are, it comes out of honesty in your mind also. So that you can't say the time. It could be some more time also for some people. For some others, it could be less also.
Excellent. I can see some more answers in the chat box. One is Dr. Lata says 2 to 3 minutes, and then Dr. Raki says eventually you build rapport. I completely agree with the explanation that all of you are giving. Building rapport does not take time. It does not take time. It's not a factor of time, but it is a factor of intention. Do I want to make rapport? Do I value building rapport? Those of us who value building rapport, we don't make any extra effort. The moment patient comes into my visual field, I lift my head, I make eye contact, I smile, and I say, "Aye, come in, please." Usually patients greet us. So we respond by greeting, "Namaste, come in, please." And you show them where to sit. Honestly, your building rapport has already begun. Building rapport does not require time. But unfortunately, a lot of our, young doctors sometimes do not consider these finer details of building rapport as important and essential. So therefore, sometimes patients feel that we are not making any connection with. Do you agree with me? Am I audible?
Yes,
Yes.
madam.
No.
But somehow I am not able to probably receive answers from you. So, so we may
One
have to take
suggestion,
more time.
if you switch off your video,
Yeah.
actually that will be much better. Not
So
for
is
us,
it, my
for us.
video also?
Yeah, the video is like breaking in between. Only the video, not the audio.
Okay, okay. So do you suggest that even I can switch off my video if you think my video, switching off my video will improve the quality?
It may help you, madam. Like for us, actually, it is always you should be present there. I think.
I know,
Yeah.
that's true. For me also, that gives a good feeling when I can see all of you and get feedback that yes, you are there with me. So I would request, I think this is one skill. Please teach your doctors, your nurses, your front desk staff, your all healthcare providers to build rapport. Sometimes they come at the reception. The person at the reception is busy doing something, which may be a genuine work, but the person does not lift head, person does not make eye contact, person does not wish. How will the patient feel? How will the patient feel? So building rapport is the first skill that I would recommend that each one of us should practice. Prompt attention and building rapport. So let me show you just one slide and then we move on to the second skill that I want to recommend. And as I said, yes, Raki, I completely agree. They would feel ignored. And that's a very sad situation when they come to us and we don't pay them attention and they feel that we are not, interested in attending to them. They feel very dejected, actually, very honestly. So as I said, building rapport actually starts in the first minute of your interaction. They start having a feeling how happy we are to deal with them, how keen we are to deal with them. And as we are discussing, and there's a realization that building rapport is not just for the patient, but for all of us. And it does not take time. It's a matter of intention, then a matter of time, honestly. And then, is it being friends, if I may ask you? Is it being friends?
No.
I don't think so.
No.
It's not. Absolutely.
No.
So somewhere we fear if I build rapport, the patient will start treating me like a friend, or patient may not give me the respect that I expect the patient to, give me. So therefore, we kind of have that, kind of a attitude that we maintain distance or we stay distant from the patient. It is being friendly and not being friends, honestly. That clarity we need to have, that it is not being friends, but it is just actually being friendly. So very quick, tips to building rapport. The moment person comes into our visual field, if we pay them prompt attention by making, looking at them, greeting them, and then smiling, especially if it is appropriate, unless the patient is in severe pain or there's a serious condition, of course, we all know that we should not be smiling at that moment. Offering them place to sit. A lot of time, if we don't show them where to sit, they feel that nobody is caring where where to sit or tell me where to sit. Then introduce yourself. How many of us introduce ourselves to the patient? Do we introduce? Do we tell I'm so and so?
I do all the time, especially with the first time.
Especially for the first time, it's very important because they are meeting you for the first time, and if they, especially, the problem is with the young doctors. So, for example, when I ask this question to interns, and I ask them, do you introduce yourself that I'm an intern? They would normally say, no, we don't introduce. And when I ask them, why don't you introduce? Their usual, answer is that if I introduce, the patient will not share all the information and history with me. So I help them understand that, when you introduce yourself, their expectations actually get realistic. When they know that they are talking to an intern, they would know that how much you would be knowing or how much you would be, able to kind of explain to them. So introducing is very important. That also kind of give them clarity. Sometimes young doctors come and say that especially female doctors. So they'll say the patient treats me like sister and they call me sister. But if you go and introduce yourself that I'm Dr. So and so, they would know that you are not a nurse and you are a doctor. So that's the importance, that your patient should know that who you are and whom they are interacting, especially for young doctors. And even, for example, a person at the front desk, they should know that if I introduce and tell them that I am the person I'm going to help you, or I'm floor manager, or I'm care coordinator, or I'm the nurse on duty. So they will know that who is the person I'm talking to. Then asking patient's introduction, especially in a heavy OPD. There's a possibility that you may have a patient and you may have an OPD slip of another patient. So it's always good to ask patient's introduction by directly asking what's your name. So I was taking a session for a group of nurses. So one of them said that there came, she was working in an injection room. So she said that there came a patient and I just asked her, are you Geeta? She said yes. So, and then she asked, you were bitten by a dog. And she nodded. The patient nodded. She didn't say yes, she nodded. And this nurse, she gave her the injection. And later on, they got to know that neither she was Geeta and nor she was actually bitten by a dog. She had come for another injection. So when we don't take patient's introduction, there's a risk of, identification failure. So it's very important to ask patient introduction. And not only patient introduction, it's also important to take attendance introduction. May I ask you, why do we need to take attendance introduction? Why is it important to take attendance introduction?
One of the reason is same name. So there can be two patients with same name.
Mm.
So naturally the attendance will be different for them. Are there a place of from where they come? Generally, I do
Okay,
that.
confirmation. Okay, please. Okay, but that is for the patient, I think. Our concern is now I'm saying somebody who has come with the patient, you would want to know who is the person. I think Dr. Lata has one by one. Yeah, 1 second. Let me read the answers in the chat box. Dr. Tanzila has written to know relevance of the history. Okay. And Dr. Rakhi says relationship between them. Yes. Dr. Lata, you were saying something. You wanted to make a point here.
Yeah. Same, especially when we deal with elderly patients who are not oriented and all. Is sometimes what happens is the attendant is some neighbor and they don't know the proper history. And if we ask them, it's like building of stories and we don't get a proper history. They give yes for how to say no to what questions we are asking. So usually when we take, it's always better that we take the history from an attendant who is staying with the patient. That is not some neighbors.
That's one of the reasons. Absolutely. So we know whom we are talking to. Absolutely right. Any other point, Doctor? I think Dr. Harimon and then Dr. Sonia, both of you want to say something. Dr. Harimon,
very important to know how much to disclose, because the patient confidentiality is there. Sometimes it could be just a friend accompanying and you can't tell everything to them. So it's very important to know how close the patient's attendant is to the patient. How much to discuss.
Absolutely. Wonderful. I think that's an important reason. Thank you so much for adding that. Yes, Dr. Sonia, anything that you wish to add to what does?
Actually, many times we give all the information and then they back out and say that we haven't received any information at all. So if we have the proper attendant's name and the relation, which is, which is documented in the case sheet as well. So it's easy for us to say who received the information or who heard on behalf of the patient. So, and similarly, if they're very, they may not be related, they may just be accompanying the patient. They may not be very keen to know also, and they may not know also. So we have to deal with the different attendants in different manners. So it's good to know who it is.
Absolutely. I think that's
a mentally deranged patient, you have to get the history from the attendant. Am I right?
Yeah. Yeah, very important. So that means we really need to, know the relationship so that we know that we have the right information coming from the attendant who knows about the patient. I can see some answers and then I'll come back to Dr. Asha. Give me a second, Dr. Asha. I can see Dr. Deepa has written to give instructions. Yes, we should know how close is the attendant so that you can give the instruction accordingly. Then, of course, medical legal case. Yes, Dr. Mini, I agree with you. In those cases, all the more it is important to know should we really be sharing the information with the patient attendant or not? And then also to know how sincere the attendant will be. That's also very important, Dr. Rajalakshmi. I agree with you. And then Dr. Deepa has also mentioned that to explain the situation to a responsible attendant. Yes, ma'am. And then how much to disclose? Yes, I think this we have covered already. Thank you for adding that point. I think one of the important reason why, okay, Dr. Asha, you have a point to make. Please go ahead, ma'am. Go ahead.
No,
Yeah.
I wanted to stress when we see kids, when we see children where we cannot get the history from them, we need to know if the attendant is reliable and the history should be from the attendant. So many kids, they come with their grandparents and all, they'll say, oh, I don't know, the kid is not staying with us, so no history is reliable. In our scenario, the fathers are all abroad. They come and bring the child. You ask them, he says, I just landed yesterday, so I do not know the history with the child.
Very true, very true. So even I think Dr. Paul has written the same thing, reliability of the history is a question. So it's very important to know who is the attendant. Absolutely. Yes, Dr. Rafiq, I think you wish to make a point. Go ahead, please.
I am actually, we want to know the level of knowledge of the attendant, because many times patient must be accompanying with a doctor or the nurse or something. We started saying in very simple languages, and finally we got that he's a doctor, he's somewhat senior to us. So we want at what level of language, medical terminology we can use by knowing the like whether they're a doctor or nurse.
Absolutely. So I think we have understanding that it's very important to know who the attendant is. Also, sometimes, the dynamics, family dynamics could be not very conducive to asking some pertinent questions, and the patient may not come out truthfully. For example, a lot of time when a daughter-in-law and mother-in-law comes, there can be a conflicting situation, and the person may not come out with truth. Sometimes certain questions, I mean, we may feel, not appropriate to ask in front of a attendant who is not actually very closely related, and maybe patient may not feel comfortable answering those questions. So it's very important to know who the attendant is and what is the relationship, and especially when it comes to explaining, like for example, even in psychiatry, OPD, or drug abuse and other situations. Again, we need to really be careful that if we are going to share the information, it could be calling for a problem, because the patient's information is privileged information, and the patient may not want that information to be shared with others. So we have to take patient's consent. So that's, I think, in a nutshell, I think we have understood that it's very important to not only take patient's introduction, but also make sure that we know who the attendant is and what is the relationship. And then small talk before the big talk. So what exactly we mean by small talk before the big talk?
To gain the confidence of the
Confidence.
So what questions do you think we can, or what statement can we make, or what questions can we ask to do a small talk before the big talk?
Friendly questions.
how far you've come traveled.
Where have you come from?
Your native place.
Absolutely.
Native place.
Absolutely.
First visit.
Where are you from? Yes,
Mhm.
that's a very regular question we ask. Where are you? Where are you from? Who is this with you? Did you have to wait very long? Who guided you to come here? So this is like kind of, first of all, gives you an idea about, I mean, it makes the patient comfortable, and you also become comfortable. Plus, you also get an idea about patient's language skills. So when they answer your question, you get an idea, okay, how conversant the patient is. I can see a couple of answers in the chat box. Where are you coming from and who is this with you? Yes, I think Dr. Manju, that's a very good question. Dr. Aki has asked about family. Again, wonderful, because that's what is the idea, that we start in an informal way and then we go and move to the actual problem for what the patient has come up to. So that's again to make comfortable, to make the patient feel that, okay, we are also human being and we are treating them, and so if you look at the whole thing that I've written, I don't think it will take more than a minute to complete this. But if you do this in a systematic manner, patients start becoming comfortable. 50% of the diagnosis can be made from the information the patient shares with us. But for that, patient has to become comfortable and we have that trust that, okay, we are there to help them. And building rapport actually paves the way for a wonderful interaction and satisfaction for both the doctor and the patient. And of course, when the patient is talking, we need to demonstrate interest and respect by listening to them attentively. So the second skill that I would recommend to you is paying prompt attention and attentive listening. So what exactly we mean by attentive listening? Can I ask you?
Yeah, attentive listening is not listening by distraction. You're focusing on exactly what the patient says. There should be total eye contact. You're interested in what the patient says. You can be distracted by, you can look at the things and you can look away. That is not attentive listening. You can be
understanding what you hear.
So that means we have to demonstrate that I am listening to you, and we have to actually leave everything and pay 100% attention to the person. I can see some answers in the chat box: appropriate body language and eye contact, listening with empathy, body language, minimal interruptions. So definitely all this is going to help us in demonstrating that I'm listening to you. Let's do a small activity. I am going to send half of you to the waiting area. But can I request all of you to have your camera on? So I request everyone to have your cameras on. I can see only Dr. Nambiar and Dr. Vasudevan with their camera on. Others, can I request you to have your camera on? Or is your camera on? If I'm not able to see.
Yeah, our cameras are on, ma'am.
On.
Oh my goodness, I'm so sorry. I'm not able to see anybody. Yeah, Dr. Rajalakshmi, I can see you now. Okay. It's okay. If I'm not able to see, maybe some network issue on my end. So I'm going to send half of you to the waiting room. And the task that I'm giving you is that I'm sure in your practice, there must have been a situation where you had a wonderful opportunity or an incident where your patient was very happy, very satisfied with you, and literally came complimenting to you, telling that I'm very thankful to you for what you have done for me. I'm sure in your such a long practice, there must have been many such incidents. So I would request to those who I'm going to put in the waiting room to just recollect that incident and be ready when I ask you to come back and share with your partner. But I'm giving you a few seconds time to go in the waiting room and then think about the incident. So I'm not choosing any, but I'm sending as per the name that is coming in front of me. So Dr. Rajalakshmi, is the task clear to everyone? Is the task clear to everyone?
Now, what we understand is think about your situation where a patient was very happy with you.
Exactly. So you have to really recollect that incident, and I'll be asking you to come and share that incident with your partner. So I'll be putting you, with the partner in the breakout room. So I'm putting you in the waiting room so that you can, think peacefully and come back. Okay. And then Dr. Rajalakshmi has sent her. Dr. Asha, I'm sending you to the waiting room. Okay. Then Dr. Paul, I'm sending you to the waiting room. Then Dr. Vasudevan, I'm sending you to the waiting room. Okay. 4 people have gone. Dr. Deepa, I'm sending you to the waiting room. And then Dr. Manju, I'm sending you to the waiting room. 6 people. And then Dr. Rafiq, I'm sending you to the waiting room. Okay, how many people have gone? 7. So one more I can send. No, 7. 7 in the 14. One more person I can send. Okay, Dr. Harimon, I'm sending you to the waiting room. Okay, so 8 people are in the OP in the waiting room, and I have 1, 2, 3, 4, 5, 6, 7. 7 people with me. Am I audible to all of you?
Yeah.
Okay. So your task is when I'll put them in the breakout room with you, they will definitely share their story. But you all will have to demonstrate that you are not interested in listening. So maybe you will start talking to your family member, or you will start attending the phone call, or you will not, make eye contact with them. You will not nod, you will not kind of show interest in what they are, saying. Is the task clear? Is the task clear to everyone?
Yes, ma'am.
Yes, ma'am.
Yes.
So should I bring them in?
Yes. Yes, ma'am.
So I'm going to bring them in, and first I'll put you all in the breakout room, and then I will put them in the with you. So give me a second to increase. 1, 2, 3, 4, 5, 7. So I request everyone to join the breakout room. Okay, so I'm going to add you to the breakout room with your partners. Give me a second to admit everyone. Okay, give me a second. I'm going to put you with your partner in the breakout room, and I request you to share your experience with your partner. Is the task clear to all of you? So please join the room that you have been asked to join. I'm waiting for everyone to join in.
Okay, ma'am.
I'm waiting for everyone to join in, and I want at least one or two of you to share your experience who were speaking, who were doing the talking.
Who are doing
Who
the
would
talk
like
or
to?
Are you?
Who were sharing their experience?
With the partner.
Sorry, I'm not able to hear you.
Has to explain what the other person has told. Madam, you said the partner to whom we spoke to, they have to explain?
Yeah, I can hear you. Yes, please go ahead.
See, what I understood is that that partner to whom what you are speaking, or I have to speak.
I suppose the person who
You
spoke
are
has to speak.
supposed to share your experience with the partner. Those who were having
Talking.
the
Talking. Who was
Yes,
speaking?
Dr. Asha. Yeah.
Yes. My pair was Dr. Mini, and I was so excitedly speaking about this patient who came to me and who made me so happy. And she was excellent in acting instead of looking at somewhere, talking to somebody on the phone and things like that. I mentally thought, if I'm sharing something which is happy, exciting to me, if this is how the recipient is, what will it be if I'm already in a worried or a frightened state? A happy sharing itself made me irritable in 1 minute. So, and Minnie was good at acting.
So that 1 minute gave you the taste when patients come to us, and if they feel that we are not listening to them attentively, how they must be feeling. How they must be feeling. Thank you for sharing that experience, Dr. Asha. Yes, Dr. Harimon, I think you have a experience to share.
My partner was Dr. Raki. She's really good in what she's doing. She convinced me in the initially and irritated me. Maybe it lasted for 15 seconds. Then, of course, I got the hang of it. I said, oh, this is the game. And we both started laughing.
Oh. But initially, I'm sure you must have been a little upset at least.
Yeah, 15 seconds it took me that this was the class.
Okay. Thank you. Yes, Dr. Manju, you want to share your experience. Please go ahead.
Yeah. Yes, ma'am. Dr. Tansil is still acting, I think. No, he stopped. Yeah. I'm a psychiatrist, so I was relentless in explaining my case. I understood that he was acting a few seconds into the explaining my case, but then I finished telling him all about it, and he was the least interested. Yeah,
So
it really does give us a taste of how our patients would feel if we behaved even slightly like how our partners behave today.
Absolutely. And they
Actually,
not
ma'am,
get
I want to
upset.
add one more thing.
Go ahead, please.
Actually, halfway through, I was acting, but later on, actually, my charger got malfunctioned. So I was not acting.
It became realistic.
I'm sure this was just to give you a taste of when the other person feels that we are not attentively listening, how they would feel. When patients come to us, they come with a lot of hope and a lot of time, especially in government setup, they wait for 2-3 hours to meet us in the OPD. And sometimes we don't give more than 2, 3 or 5 minutes because of the heavy OPD load. And if those 2-3 minutes, if they feel that we are not listening to them or we are not interested in their information, they feel really dejected. So just today, I received a phone call from head of the department, gynae of one of the hospitals. She said there is a ruckus in the OPD and this patient has called police and this patient has called media. How do I handle? She's a friend of mine, so she was discussing with me. She said, "What do I do?" I said, "Go and talk to her and calm her down and segregate her from public and then ask her what is bothering her." Then after an hour, when we talked, she told that this lady, she was separated from her husband and she was childless and she had come here for treatment for her infertility. She waited. She was here at 5 o'clock in the morning. Got her OPD card made. 10 o'clock her turn came. The moment she came in the OPD, in the chamber where the residents were sitting, the resident got up and she went out for some urgent work for another patient. Now, this lady was not told anything that she has to wait, for how long she has to wait. She really got bucked. She literally started, shouting at the other staff member, and there was a fight, and then she kind of, created ruckus, and she called police, and she called, So imagine sometimes the patients also overreact because of the burden that they are carrying behind them, which we are not aware of, which we don't know. So how important it is to listen to your patient, even if you're giving those 2-3 minutes, it's okay. I'm not saying that if you have only 2-3 minutes, you can't do anything about it. But then, am I giving my 100% attention in those 2-3 minutes? That's very important. So if I may ask you, how can we demonstrate that I'm listening to you? What else can we do?
Body language, leading questions.
Body language, definitely. Posture, very important.
Leading questions.
Leaning forward.
Yeah, slightly leading, that I'm trying to connect with you, I'm trying to understand you. Absolutely. Absolutely. What else?
You can just nod or say yes. So you don't tell anything, you don't give a reaction, but you just show that you are listening.
Yes, that's a very good way. When you nod and you
smile.
Positive gestures. Like
Smile.
Smile is appropriate. Absolutely. Smile if it is all right to smile in that situation. Absolutely, that will definitely communicate that I'm understanding or I'm agreeing or I'm getting the situation. So it's not really important.
Might be
Yes,
inappropriate also, because especially in cases like when we are going to listen to the painful symptoms or when it's a issue with a lot of pain and emotionally upset patient, smile is out of place there. So
absolutely.
Be careful of where
That's
you're
why whenever I say smile, I always say if it is appropriate. I'm always adding this point, if it is appropriate. If situation is okay, if things are not serious, if there's nothing very grave, it's appropriate to smile. But when things are not okay, patient is in pain, patient is upset, or patient is actually deteriorating, of course we all know that we need to be more composed in that situation. Absolutely. I thank you for adding that.
Madam, can I say something?
Sure, please go ahead. Yeah, go ahead.
You asked how a person should be. I never felt that my partner was not listening.
Acha.
To whom
So
I
your partner
spoke, he was smiling and listening to me.
Who was your partner? Dr. Lata?
Dr. Lata. I never felt that I was irritated or. So I think
So
her
maybe,
gesture must be better.
so maybe she thought that since it's an activity, so she was also playful about it. Could that be the reason? Dr. Lata can give a reason.
My acting skills are very bad, madam. I tried, but
She was smiling at me, answering all the questions I asked her also.
and by default, she must be a good listener. That is why.
Yes.
Yeah. Yeah, absolutely. But all of them were given the instruction to, kind of act that they are not interested in listening to you. And that was the idea, to give you a feel for a couple of seconds that it is not, very easy to be in a situation when you are not heard, when you feel that other person is not listening to you. So we have covered almost everything about how to actually demonstrate that I'm listening to you. So first of all, it's important to face the person rather than looking left or right. It's better if we look at the person, especially in setups where we have a laptop or an iPad where we are simultaneously adding patient's information. If you don't look at the patient, if you don't make adequate eye contact, they get a feeling that probably we are more busy doing some entry. They are sometimes not even aware that actually we're entering their information. So it's not only important to make adequate eye contact, but also let them know that I am adding your information to the computer, and is it okay if I'm simultaneously doing this? So they get an idea that you're not doing any personal work, but you are actually kind of entering their data on the computer. Smile, as I said, only if it is appropriate in this situation. One should avoid multitasking. A lot of time we start writing probably sometimes the treatment, or we start filling in the blood investigation form. They have a feeling that we are not giving them 100% attention. You have already mentioned that if you lean forward, that shows that you are interested in listening. Nodding, you have already mentioned, which would communicate that I'm listening, I'm understanding, I'm agreeing with you. One should avoid interrupting, especially for initial couple of minutes, because then they are able to, in a flow, they are able to talk about their problem. At least for first 1 minute, we can allow them to speak their mind, and then maybe we go ahead with some direct questions that we need to ask. Some important point that you need to further investigate, if you note down, you will not miss anything vital, and you will know that, okay, this is something I need to further clarify or get more information. But all that we'll do once the patient stops, talking. So that is number 2 skill. Attentive listening, again, comes with lot of practice. Although we all say I'm an attentive listener, trust me, lot of us actually either interrupt the patient, or we get distracted, or we start doing something, and patient gets a feeling that they're not being heard fully. The third essential skill that I would recommend to you is positive and helpful attitude. What exactly we mean by this? What exactly we mean by positive and helpful attitude?
Help them to bring out what is in their mind by leading questions.
I'm sorry, could you repeat, please?
Asking leading questions to bring their views out and what is the real problem.
No, my question is, what is the importance of positive attitude? Why should we have positive attitude when we are interacting with the patient? And positive attitude towards what, actually, if I may ask you?
To what they say. Because then only they will open up, their real problems.
So towards patient
confidence. Build their confidence.
To have the confidence and to fully expose what is in their mind, and to have a belief in you, trust.
Okay. I agree, because positive attitude will make them comfortable and open up. I absolutely agree. I can see 3-4 hands. Okay, Dr. Lata, if you may, I think you have a point to make.
One is, with our attitude, we can make them feel that they've come to the correct place.
Exactly.
And definitely, they're going to get a solution for their problems.
Exactly. That is what.
For that, whatever help from our side, we'll be there to provide. So that is going to build up the confidence in the patients.
Agreed. Wonderful. Thank you. Yes, Dr. Asha, you have a point to make. Please go ahead.
Yes, on a positive attitude, I would think is for them not to find fault with what they have done wrong or what negative things they've already done. Instead, stressing on the positive side so that they could hope for an improvement always, rather than say, oh, the outcome is going to be bad. I don't think nothing can be done, or it's going to be fearful. The other attitude, whatever positive you can offer them, you start off with them, so that they'll open up more and try to find out more solutions to their issue.
And especially if they have not followed the regime, if they have not, taken proper treatment, A lot of time we get upset and then we become judgmental
Guilt,
and then we
yeah.
pass some sarcastic comments also. So, I mean, staying positive in terms of also your expression is very important. Thank you for bringing that point. I think that was important. Yes, Dr. Harimohan, I think you have a point to make. Please go
Yeah,
ahead.
I do a lot of first day oncology counseling, those who are diagnosed with cancer. So generally, some of them are already upset because they have disseminated malignancy. And they already know they come with that, but they're coming probably walking and they're perfectly all right now. So I generally stress upon that. I said, okay, they know about it. They tell I'm in 4th stage. I said, okay, forget about the stage. The idea is you're not coming on a stretcher or a wheelchair, you're coming walking and you're going to take the treatment in a better way than what you feel. So definitely we can look forwards and we'll work as a team to make you the best out of it. So generally, I have found that helps a lot because they come very depressed because they already know their state. Somebody has told them, they're upset about it. And then we tell what are their positivities, like whether they can, like for example, a bedridden patient, we won't be giving him chemo or any other treatment because that is not done. But here,
absolutely. Dr. I can come to you.
Yeah. So we look at the performance status of the patient is good, then he can at least go for the treatment. May not a cure, but I tell them the positive part of what they are having right. And generally they are happier.
Wonderful. Thank you for bringing that point. So, Dr. Rakhi, give me a second. I'll come to you. I also want to talk about positive attitude towards, towards patients from our side and towards our profession, towards the task that we are doing. Does that also have influence on the way we conduct ourselves with the patient? Do you think that has an influence?
Meaning,
anybody? Yes, Dr. Rakhi, you wish to answer?
Yeah, no, I didn't get what exactly you wanted to know, ma'am.
Okay.
Just repeat it, please.
So right now, the answer that I'm getting from all of you, that there's a assumption that we are trying to enthuse the patient with positive attitude because we think the patient, if are given positive thought process, they'll go back, more enabled and also, feeling better. I agree. I completely agree. That's a very valid point. But my other part of the question is the importance of, positive attitude coming from us towards patients, towards our profession, towards society, especially in the today's context where we see the relationship between the doctor and the patient is, not really very, trusting. They are not trusting or they're. So in that case, how about our attitude towards them, towards patients, towards their family members? Does that have an influence on the way we conduct ourselves?
Yeah, sure. Yes.
Because how we consider our work, a lot of time we are unhappy with our profession, with the setup, with the hospital. So that also affects the way we conduct ourselves with the patient. Dr. Rakhi, you have a point to make? Do you have any other point to make?
No. Actually, you carry on, ma'am. I will, no, not right now. You carry on.
Okay. Thank you. So as I said, being positive and helpful, like Dr. Harimohan said, it helps actually patients, have trust that they're at the right place. This was mentioned by one of you in the beginning itself. And then also it motivates them to stay in treatment because they feel that they are in safe hands, they are in the right place, and there are people, who are willing to help. And even simple thing like your willingness to engage in conversation with them is a sign of, positive attitude towards patient. So that's the way patient would view when we don't, answer their questions or when we don't talk to them. They feel that we have a negative attitude towards them or towards our profession. So that's one more skill that I want to, emphasize. Skill 4 that I would say is very important is treating the patient with respect and dignity. A lot of time in number of places, our conduct with the patient gets varied. Like if you remember last time, one of you had mentioned that the patient is is abusing drug or is an alcoholic. So we look down upon the patient. in number of places, especially if I talk about maternity, care, a lot of time we are not very respectful towards patients, especially when they are in labor pains. We are rude with them or ill-treat them sometimes, and also physically also sometimes we hit them. And also, do we differentiate when we deal with the patients who are educated or financially well off, they look good or they're well behaved? Is there a difference the way we deal with them?
Yes.
Frankly
Yes.
speaking, I suppose so.
Yes.
It is
They
always
are a little wary of them.
Yes,
So unknowingly.
Yeah.
Unknowingly.
Yeah, go ahead, please. Go ahead. Yeah.
It is, I suppose, not the financial or the whatever, but the way they speak to us. We naturally, with an empathy, we tend to speak in the same language they speak to us. So if it's a very polite, educated way they talk to us, we naturally reflect in that same way. I suppose that is something which comes naturally, whether we like it or not.
Absolutely.
And it's
So
something
if the
we need to
person
work
is
on.
behaving well, they also tend to behave in the same good manner.
I think there
Yeah.
is an understanding, there is a more higher likelihood of litigation, perhaps. I think there is a lot of concern when purportedly the patient is coming from a higher class. I think that concern is there. I think there is a lot of bias from our part, where we feel that people who are not formally educated do not understand about prognosis. We feel that there is a communication gap, but it is our responsibility to actually bridge that gap and explain it in terms and manner that the person whom in front of us. So I think there is an automatic assumption, somebody who's from a rich background, there might be a greater chance of litigation. And so you tend to spend more time. And I think there is a lot of bias, inherent bias from somebody who's coming from a poorer background.
I think you have brought a very valid point, and this is what I wanted to bring in. Unknowingly, sometimes with the patient from a rural background or from a poor background, we assume that this person will not be able to understand if I try to explain. And we assume a person who is looking little educated or is financially well off or is well behaved, they will understand better. Whereas there is no evidence to this assumption.
Most of the time we are wrong also.
Yeah, absolutely. Absolutely. I agree. Yes, Dr. Lata, you have raised your hand. You wish to make a point here?
I don't know. Personally, we deal with, I work in a government setup. So for me, I feel it's more easier to deal with patients who are coming with a poorer socioeconomic status. I mean, who are ready to, who trust us and they're ready to listen to whatever we are telling. And what compared to persons who come from the other background, if they ask like, doctor, should we take them to some other place? We'll be like, okay, even if we are able to manage, because of that question, there's a tendency to refer such patients more compared to the other patients who trust us more, and they usually, eventually they take treatment from here itself and get better. So that is one difference.
So again, our personal biases come in our way, where we assume that person who is asking a lot of questions, probably they'll be better off if they are referred, they are gone. Or a person who is coming from a humble background, we assume that they will trust us, or they will not ask a lot of questions, or they will accept whatever you say. So these are a lot of our personal biases and stereotype thinking that come in our way. And they can affect the way we treat our patients. Yes, Dr. Vasudevan, I think you wanted to say something. Yeah.
Those we generally feel that those who are from the better economic status, they are more demanding, and those who are we take it for granted that they are not demanding. We feel we are more accountable to them rather than to the lower.
Absolutely. So I think the point that I want to make here is that each patient has to be treated with respect and dignity. whatever their caste, creed, socioeconomic status, background, irrespective of that. Even if they have shared some of their sensitive information, that kind of, shows probably, a sad part of their story. But then we cannot ill-treat them for that reason. So we have to give them that unconditional, positive regard, because that's what the whole process of interaction is. So even respecting patients, autonomy and decision, even if we don't agree with them, the decision, if they say, we don't want to stay, we want to go Lama, or we don't want the patient to be resuscitated and they ask DNR, whatever, we still remain respectful and we respect their decision. That's the whole idea. So in our conduct, that has to be displayed very, very, very clearly. And the golden rule that I would recommend here is that please don't give the behavior that we don't want to see. Overall, if our behavior with them is respectful, and we know that, this is what I would expect from my treating doctor, I don't think we will ever go wrong on that. So these are the 4, essential skills. And the 5th one is empathy. I think that's one skill, if we all, embed in our overall interaction, you can look after most of the situations with greater compassion. So empathy is where you put yourself in their place and you look at the situation from their point of view. A lot of time we think the situation is very small and it doesn't require any intervention or any action. But if you look at it from the patient's point of view, it could be actually very painful. Sometimes a lot of aggression comes because nobody is understanding their state of affairs. So these are a couple of things that can help us to express empathy. If you listen to them attentively, validate their feeling, show that you're understanding, show compassion, stay non-judgmental and treat them with respect, mostly they feel that we are being more empathic. So if I may ask you, what are the barriers in expressing empathy? What stops us from expressing empathy? And a lot of time we get to hear this from general public, that healthcare professionals are not very sensitive to our needs and our condition. What are the barriers?
Lack of time.
Laptop time. So that means we are not connecting enough with the patient. Is that what you're saying?
No, there is a heavy rush in the OPD, and we don't have adequate time to cater to their needs or put ourselves, explain things to them. We just try to rush and pass each patient off. That is what.
So that means we are not giving enough time required for the consultation. It's more like a rushed consultation. That's what you are saying. That is one barrier. Okay. Dr. Harimohan, yes, you have a point to make. Please go ahead.
Yeah, some of us are embarrassed to be empathetic. We don't want to be emotionally too close or relate to them too much. So we want to keep our distance as a clinician, and we should not be seen as being too much into their emotion. Empathy is actually feeling what they feel. So we don't want to do that.
A lot of time in the, especially I'm talking about the government setup. So I get to hear that, sometimes there's a death in the emergency department, the dead body is still around. And residents sometimes, they are talking about where to get food from. Biryani mangwate hai, wahan se mangwate hai, uski biryani bahut achhi hai. Or they are giggling, with each other, showing some WhatsApp message or some video to each other. Even to the extent sometimes, asking the relatives to go out and cry and not to cry in the emergency department because there are other patients who will get. I don't know, how would you call this? What would you call this? Lack of empathy? Or is it more than that?
I think there is an attitude of being there, seen that you have seen enough deaths, and after a period of time, I think it loses meaning. I think that is often an issue. I think there is also an attitude that you need to appear very strong, tough, that, you should not display any kind of vulnerability. That, okay, you've seen this death, you're still solid and you're not appearing vulnerable or sad. I think those are two other issues often, because you've just seen so many of similar people with going through similar difficulties, after a period of time, it loses meaning at some level.
So will this be called as being strong, or will it be called being, empathetic?
No, it's a false. It's a facade.
See, one of the barrier in like some of you have already expressed, not expressing empathy. We think if we express empathy, we'll be attaching with the patient. So empathy is not attaching with the patient. Empathy is that you are able to look at things from their point of view and doing what best I can do to reduce their suffering. That is what is expected when we say express empathy or practice empathy. But unfortunately, we think if we practice empathy, we will get affected emotionally, or we will get upset, or we will become sad when we look at their ill health. But that's not the actual explanation of empathy. See, there are 4 different emotions we all experience with the patient. For example, there's a patient who comes in with pain and suffering, and suppose I'm there in the OPD, I see the patient and I say, please wait, and I make the patient wait for good 5-10 minutes, and I don't attend to the patient, or I don't make any effort to see who can see this patient or what can be done for this patient. Now, a patient who has come to us in pain, the pain hasn't started 5 minutes ago. Maybe they are in pain for a couple of hours. They have tried something at home that has not worked. They have even gone to the local doctor, and the local doctor has given some medicine, but that has not helped much. And now they have come to us. So the suffering, the long suffering has been, for a while. And me not attending to that patient for those 5 minutes is actually very painful for the patient and the family, and they see it as apathy. They say it that I am not affected or I'm not concerned, and that really upset them. Lot of time, this is the reason they become very aggressive when their patient is not attended promptly. Now, this attendant comes to me and starts arguing with me and says, for the last half an hour we are waiting and you have not paid any attention, and my patient is rolling in pain and you are not doing anything. Now, I may not say the patient anything, but in my heart, I'm feeling very bad that this patient attendant has talked rudely with me. And I decide I will take another 5 minutes to look at your patient. This is antipathy. The third emotion that we often experience is that there's a lady, for example, who comes in with a child, and the child is really not well. The mother is very upset. She's literally crying. Seeing her cry, even my mother would also, start, coming in. And I also feel like crying. I get upset. That is sympathy. All these 3 emotions are not required. They are not helpful. The correct emotional response to any such situation is where we are able to look at situation from the other person's point of view, that if they are in pain and if they are upset and if they are little anxious, these are very normal reactions anybody will have if their family member is unwell. And especially if the cause of pain or bleeding is not identified, they are looming under a very big fear. And that fear is fear of death. And you can well imagine, if anybody is under that kind of a fear, what will be their state of mind and how their reaction to the situation becomes extreme without any rationality. So empathy is not that we are attaching with the patient, but if we are able to look at situation from their point of view and be more compassionate and helpful and promptly whatever we can do, if we do, that's what our patients expect. So these are the 5 skills that I would say, if you could always, not only practice, but also help your, healthcare providers, whoever, who are working with you. If you help them learn, I'm sure we can manage most of the situations that could actually turn into an aggressive reaction. So I can see some of the answers. For example, Dr. Tanjil has mentioned that we are into defensive practice. I agree. Dr. Manju says prejudice, being judgmental, authority, all can be barriers to empathy. Yes, I completely agree. They become barrier to empathy. And then Dr. Navia says very often some of the patients try to express their knowledge on the treatment part, and that irritates the doctor. The doctor refuses to show empathy. See, I agree. Now, patient is trying to show knowledge. I can either become aggressive and get upset, or I can, in an assertive manner, explain to my patient that I understand that you know a little bit about this condition. That's very nice. Every patient should know what they're suffering with. But let's come to the point and discuss what we need to discuss. When they ask questions, again, we are not used to answering questions because that was never the way patients asked questions. So that upsets us. But then in the time to come, this is going to happen more often because patients have access to information. They Google search about their condition. They have heard from other patients. They have heard from other doctors. So obviously they'll have little knowledge. We can't be annoyed about it. We can choose to be annoyed about it, but then that will not help. But we can definitely use that knowledge to help them learn more. And then also through your expertise, you can show that you are master of this subject and win their confidence. So it's again an art and skill that you have to learn to handle even those situations where patients know and they try to show their knowledge, but not being empathetic is not the response to the situation. That's what probably I want to communicate here. So these are the 5 skills that I wanted you to, from everything that we talked about, the communication, the verbal, non-verbal, everything. If you can bring in these 5 things in your conduct, and not only in your conduct, but people who are working with you, your residents, your nurses, your support staff, all of them, if they learn these 5 skills, you can do tremendous change in the way things are running right now. So this brings us to the end of the session 2, which we left incomplete last time. Any questions about it before we move to the session, please? I can't see any response verbally, or should we move further? Should we move to the next topic?
Yes, ma'am.
Am I audible to you?
Yes, ma'am. Yes, ma'am.
Okay, thank you. Thank you. I thought that maybe there's some network issue. So the next topic that we are going to discuss today is how do you go about designing a program? Because as I said, the Master Trainer program is all about also learning how to run a program, how to design a program, how to facilitate a program. So these 2 sessions, session 3 and 4, will be devoted to go about designing a program and then facilitating a program. So if I may ask you, how do you right now design your program? If you could write in your notebook, if you were keeping a notebook with you, if you could quickly write the initial points, what all do you do when you design a program? Then maybe I will ask, some of you to read what you have written, but only pointers, not details, just pointers. So what all do you do when you design the program? You take a minute to write in your notebook, what all do you do to design the program? Maybe you can write in your notebook, and then I'll request some of you to share your points. Are you all doing it?
Yes.
Thank you. Thank you. Because I can't see you, so I don't get that visual feedback of what is happening. So if you have written, I may ask you to share 1 point each one of you. What all do you do when you design a program right now? 1.1 person. Raise your hand and then, yes, Dr. Lata, you're the always first one to raise your hand. Yes, go ahead. But just 1 point at a time. Yeah, go ahead, Dr. Lata.
Unmute.
You're on mute, Lata.
Unmute.
What
Yeah,
I'm
please,
trying to
yeah.
convey through this program. So that is the intent to convey. So that first I'll decide.
Okay, what is the intent of the program? Wonderful. Thank you. Thank you for that. Yes, Dr. Asha, go ahead, please.
Decide the topics depending on the target audience who's listening to it.
Okay, so topic is decided based on the target audience. Okay, thank you. That's a very good point. Yes, Dr. Menon.
How much time do you have to actually deliver whatever the intended topic is?
Could you please repeat? I could not get the message.
Time. How much time do you have to?
Okay. How much time we have? Wonderful. So that's another point that you consider. Thank you. Yes. Yes, Dr. Rakhi.
Yeah, first of all, I would select my target audience. Whom do I want to talk to? Who do I want to, yeah.
Okay, that's a good point. So target audience you need to know. Great. Yes, Dr. Rajalakshmi, go ahead, please.
How to hold their attention and interest in the program.
Okay. Wonderful. So you also consider that if, okay, I have to deliver this topic, so how do I hold my audience's attention and how do I make my program impactful? Wonderful point. Agreed. Yes, Dr. Mini, go ahead, please.
I would select the topics which ought to be covered and the language to be used, depending on the crowd, like whether it is a light crowd or a educated crowd or a public crowd. Then according to that, I will design the words, the topics, and the way of communication.
Okay, very nice. Now we are going into finer details of designing a program. Thank you for that point. Yes, Dr. Deepa, please go ahead.
Content is selected depending on the target audience. Then we plan sessions, and each session we have to have a lesson plan. That is how we deliver the content, whether it is interactive, when we add activities like role plays, discussions, like that.
Okay, very nice. So that means you also consider the pedagogies that you are going to integrate in your session. Absolutely, that's a wonderful point. Yes, Dr. Tanjil, go ahead, please.
Whatever topic I select, I'll be starting with a story so that all the audience are totally interested in that. And later on, I'll explain the concepts, whichever they want.
Wonderful. So you're talking about the pedagogy, that what pedagogy will help you to start your topic in an effective manner so that your audience get engaged and they become interested. Wonderful. Thank you for that point. I think that's a way. Any other point from anybody else who would like to say, what all do you do when you are designing a program? So a lot of you have talked about the pedagogies and, integrating them in your program so that your program is effective and engaging. Anything else?
I do a dry run at home.
Okay, you do a dry run at home. Okay, that's a good idea.
Pre-test.
Make sure that your program goes. Sorry? Yes, Dr. Lata, you are saying something?
A pre-test.
Okay. Okay, a pre-test so you prepare your pre-test and post-test before you run the program. Am I right? This is what you're saying?
Yes, yes.
Okay, thank you. Yes. Yeah.
One may have to recollect the stories related to oneself, whatever has happened in the practice, because sometimes spontaneously you may not get a proper story pertaining to a particular situation.
Oh, yes.
So you'll have to prepare.
Although it might appear, Dr. Sonia, although it might appear that as though you have suddenly thought of this story and you are sharing.
But
in your plan of listening, you have to be. I agree. That's wonderful. That's wonderful. Yes, Dr. Harimon, you wish to make a point. Go ahead, please.
Yeah, when I design a program, I'll be very clear about the end result. What am I going to gain out of it? Based on that, the program will be designed.
Who is going to gain? You or the audience?
I'm sorry, not I gain out of it. What will be the reason for the program? What is the program to achieve?
Reason for the program. Agree. Thank you. Yes. Yes, Dr. Deepa, go ahead, please.
Time management, because it should be over within the prescribed time.
Very good. I think Dr. Menon mentioned the same thing, that we have to keep the time frame in mind. Sometimes the session is for 5 minutes and sometimes it is for 5 hours. So accordingly, you will have to, put in the content. Yes, Dr. Asha, you have a point to make. Go ahead. And then Dr. Manju, and then we start the next discussion. Go ahead, please.
If you have more than one speakers, we are choosing more speakers, have an interaction with the other speakers to get an idea which areas to be covered, so no overlaps are there and things like that. Coordinate between the speakers.
Absolutely. So faculty should really know, who is going to cover what and how much they're going to cover and how they are going to cover. Great. Yes, Dr. Manju, what is your point?
Asha just said what I had to say, ma'am. That's what I wanted to add, apart from all the other points. When we are designing a program, and even if it's a one-day program, I would not be the only speaker. So I would choose the faculty accordingly, according to their strengths, and I would discuss it with them beforehand.
Wonderful. Thank you for so many points coming from all of you. I think you have covered most of the things, and there are a couple of things that I'll be sharing with you. How about training need assessment? Training need assessment. What is training need assessment?
Whether the target audience needs the training at all, or what is their pre-training level of understanding about the.
So that means much before we decide the topic, much before we decide the target, there will always be a reason why we are going to do the training. Through some mechanism, you get to know that either I need to upgrade the knowledge of my staff, or I need to do skill building, or I need to, train them into something. So for that, we do training need assessment or training need analysis. I think that's the first step we need to do. So what are the different ways to know the training needs? How can we know the training needs? Why do we need to do this training?
A discussion with the intended audience.
Okay, that's a good idea. Discussion with the audience, you will get to know. Okay.
Feedbacks from the patient.
Sorry?
Feedback forms. Feedback, patient feedback.
Feedback and complaints coming from the patients will give you, okay, this, we need to train our staff into this. Excellent. What else? Dr. Lata, yes, you have.
Litigation.
Litigation. If you're having a lot of complaints, a lot of, fights and arguments and litigation in one place, that means this area requires more input, more training, more upskilling. Yes, Dr. Lata, go ahead, please.
Present trends. That is, we are taking this communication skill training because there's a lot of hospital attacks taking place. So that is the need for developing of communication skills among the healthcare workers. So whatever the present scenario happening through medias,
so So there are so many ways to actually do the training need assessment. For example, some of you said feedback from the patients will tell you that, okay, this area requires more input, no more training or more functioning. Or maybe when you ask the audience, if you ask the participants, and coming from them, you will get to know that, okay, this is one area the staff is not very confident and they feel they need to know more about it. So you decide, for example, POSH training. I mean, a lot of time hospitals and other places, they get a POSH training done, because we know not very many of us are very conversant with POSH, POSH Act. So we should know that, there's a proper law around it, and each one of us should know that we have to practice code of conduct to prevent any sexual harassment case in our hospital. So you do a POSH training. Similarly, for NABH, if you ask somebody to come and talk about NABH, because you want to go for NABH accreditation, so you decide, okay, let everybody know what exactly we mean by NABH accreditation and what all we need to do. So you want to create awareness among people. Similarly, after doing this program, you're going to do clinical communication programs for your doctors, nurses, and other staff. So you will definitely have reasons to do that training. You will know where to do. So for that, what would work is, first of all, we need to find out what are their training needs. And as I said, that there are a number of ways to find how what the training need is. One is if you go and visit the place and do on-site observation. Go to your OPD, observe your staff interacting with the patients. You will get an idea. Do I need to train my front desk staff? Observe your nurses talking to the patient. You will get an idea. Do I need to really train my nurses in, or any area where there is a public interaction? You would know that I need to train these people in effective communication. You could even ask the management, because they would know in which area they are facing more trouble or more complaints or more feedback. Even they will let you know that I think this is one area which is not functioning well. It could be not enough review. It could be not enough patient satisfaction. So they will give you a reason of information. Then sometimes, like one of you said, that if you ask them directly what training you want, even they will kind of come up with this. I can see one ask. Okay, then if you or there you could even use the tools to assess. For example, you could do knowledge assessment. You give them a questionnaire where you expect them to know that information, and if they are not able to answer well, for example, for POSH program, if you give them a questionnaire to check their knowledge, you will get an idea how many of them know about POSH. So you would know that, okay, not very many people know, we need to. Or if you want to give them an NABH training and you want to see where we stand, just give me a questionnaire to see how much they understand about NABH assessment or accreditation. You will get an idea. So knowledge assessment, skill assessment, all that can help us in knowing where we need to start. Like many of you said, patient feedback, patient complaints, that's a very good way to know. Complaints that come, suggestions that come, that also shows if a lot of complaints and suggestions are coming for a particular area, that means that area require a particular set of training. And then of course, in corporate sector, we get to hear a lot about mystery customers. So where actually somebody will come as a customer and talk to the salesperson, and then they'll give their feedback on how effective they were. Of course, I don't think in healthcare we are practicing this. Anyone who's used this as a way of assessing performance, mystery customers? Has anyone ever used? No, I don't think we are using in healthcare. But then days are not for when we'll have this kind of a thing. So once you done your training need assessment, now you develop your training objectives. What do you want to attain? A lot of time, people expect you to do miracles. They will say, okay, do a training and we expect everything to change. But actually, that's not true. That does not happen. Maybe you will be able to create awareness through your program, because behavior modification is not very easy and it requires a lot of input. So maybe keeping your objective very humble could be creating awareness. Second could be sensitizing. So if you want to, gender equality, if suppose that's on your mind, so you are just sensitizing. POSH training, even that could be, more sensitizing. Imparting new skills and knowledge, if that's the purpose, that could be one of the objectives. To bring change in the attitude could be an objective. Promotion and growth can be objective. And aligning the employees to the vision and the mission of the organization could be, purpose of the training. Like for example, a lot of hospitals have induction training program. The whole idea of induction training program is to align the new employee with the way we are functioning, so that they understand the way the hospital functions. It could be skill building, it could be behavior modification. So it could be anything, but this is how you need to be clear. What are you planning to attain? What is the intent of the program? That is step 2. So based on the training needs and the expectations of the organizer, develop realistic training objectives so that, I mean, in one session, you cannot modify people's behavior. So keep your expectations very, very realistic, objectives very, very realistic. The third step is brainstorming. So what exactly we mean by brainstorming? And what do we do in this? Any idea? What exactly is brainstorming?
Discuss threadbare.
Okay. Discuss.
To get new ideas.
To get new ideas. Okay. So for example, if you're sitting as a team and you think, okay, the front desk staff needs, soft skill training. So you discuss with each other and you decide, okay, we need to talk about this, we need to talk about this, we need to talk about this. Now, some of us who are very seasoned, you would know what all needs to be covered under what heading.
Using inputs from others.
Yeah, but a lot of time we need to get input from others to understand. So when I say create a bucket list of the ideas, that is, you need to have a lot of ideas coming from others and from yourself also, so that, this will make the whole program, complete and impactful. So one of the tools that I use when I design a program, it is called eDraw Master. Let me share this screen and show you that. Okay, where is that? There it is. So eDraw Master is the tool. This has paid and free version. This has both paid and free version. I use free version, and it's more than enough for us to use this. So this eDraw Master is more like a whiteboard for you. So what you do, whatever ideas come to your mind. For example, this is the program I designed for All India Medical Institute, Jammu. So they wanted a program for the students, for their, for their faculty, and then for their other staff members. So this is the program that I designed for the students. So whatever thoughts and ideas came to me, I just kept writing them. So these are called floating topics, floating ideas. Whatever time thoughts that come to my mind, because if I write on the actual whiteboard, once I have written everything, I can't rub it, because if I have to work on another activity, I need whiteboard, I need to rub that off, and whatever I have written, that goes away. So this is more like your virtual whiteboard. Whatever ideas to come to your mind, you keep adding them like this, like floating ideas. And once you have enough ideas written, you kind of make a flow in that. So all that, this was like more like floating idea. And then I said, okay, all this will come under activities. Then these are the what should be the group size, what should be the total time available. So what do I need to talk, what I need to talk under each topic. So what happens as a result, you have a lot of ideas, and then you put them in one place, and then you organize them in a manner that creates a flow. So that topic could be, maybe the beginning of the session, maybe the end of the session, maybe the timing, maybe the pedagogies, maybe the activities that you're going to do. It could be everything, but all that you put together in one place. So I would recommend that use eDraw MindMaster. You can, download on your laptop. It's a free version that I'm using, and you can use this tool, but you can use your own tool also in case if you're using any other tool. You could even note down in your copy whatever thoughts come to you. But when you have it here, then you can move from left to right and up to down. And that's how I find it useful. So once you have all the thoughts in place, then you put them in order. So you create a flow in whatever ideas you have created. So something will go as a beginning, something will form the body of your program, and then something could be the end, how you want to end, and then finally, what is the takeaway? What is the takeaway for them? So when you put everything in this order, now you have clarity. Okay, this is the program I want to do. I want to start like this. This is what I'm going to tell them, and this is what I want them to, go take away with them. And then Now you have created a structure of whatever ideas that you have. Step 5 is now you have your training pedagogies ready. What pedagogies right now are you using, if I may ask you? What pedagogies are you using right now?
Slide presentation.
Mostly slides, I agree. Mostly slides. But since we are in, yes, go ahead, please.
Videos.
I think it's an interactive pedagogy.
I'm sorry?
It's interactive.
Interactive. Okay. Discussion, question, answer. It could be anything. Actually, it could be with a lot of things. Yes, Dr. Raki, I think you have raised your hand.
Yeah, it is role play.
It could be anything. That's what I'm saying. So it could be role plays, it could be questionnaire, it could be, what is it? Okay, 1 second. Let me, yeah. It could be experience sharing, it could be storytelling, whatever ideas that come to your mind, rapid fire round, puzzle, or whatever ideas come to your mind, have them in place, and then you integrate these where you think they will do the best, by being there. So now what you do, whatever ideas you have, you put them in order, and maybe something that you will put in the beginning. So somebody might think, okay, I'll start with the story and I will end with the video. Somebody might say, okay, I think starting with the video and then having a discussion around it will be more impactful. So maybe you will show a video and then you have a discussion around it, and then you will see that, okay, this is making a lot of sense. So what I'm trying to say, you have to really be innovative and creative in finding these pedagogies and trying your hands in integrating these in an interesting and engaging way. The whole idea is that program should not be dull. Program should not be monotonous. It should not be a monologue. It has to be a dialogue, interactive. So you have to integrate really a lot of activities in between your program so that your program becomes more engaging. Step 4 is, once you have your content ready, you have your pedagogies ready. Step 7 is develop course material. So if it is like 1 hour session or 2 hour session, maybe 1 page handout will be okay. But if it's a long session of a day or 2 or maybe a month, then you really need to develop handbook, because you want to really give them some material which they can read later on. Now, once this is ready, step 8 is to develop questionnaires for your pre-test, post-test, and feedback. It's very important to actually do a pre-test and post-test, because that will give you an idea how much of impact you have been able to make by doing this training. It could be just in terms of their knowledge, understanding, attitude, practices. Even that change is a very big change. So pre-test and post-test will give you an idea of the impact of your training. And then, of course, feedback will give you an idea where all you need to improve, what is not going well with the audience, so that you can integrate that in your future program. So this is step 8. Once you have everything ready, it's time to execute your training. So execution part we are going to do in the next session, where we will be talking about facilitating the training. But yes, you need to execute the training. And once you have executed the training, don't forget to take feedback. As I said earlier also, keep your feedback very simple, to the point, and anonymous. It's always a good idea to take anonymous feedback, especially if the audience comes from hierarchical position which is less than yours. They will never be able to give you their honest feedback if they are, if you are in authority position and they are working under you. They'll never be able to tell that this was not appropriate, or if you especially ask their name. So for them, it's a good idea to ask them to give them anonymous feedback, so that they can freely, in a very honest and free manner, they can share their thoughts. For example, in this group, I always ask you to write your name, because I believe that you are all, professionals, and you will give your feedback after really thinking what you want to say. And in case if I have a feedback that I have a doubt about, or I have a clarification to make, I can get back to you. I can ask you for your opinion. I can ask you to elaborate, so that I get a deeper understanding of what I need to change. Therefore, I always ask you to write your name. But with a larger group, especially people who are not, equal to you. It's always good to ask for an anonymous feedback because they are able to give a very honest feedback. Step 11 is evaluate your training. After the training, it's very important to sit and reflect. If you will go through your training visually, or if you try to imagine, mentally, you will get an idea what you did well, what was not appropriate, what took more time, what did not go well with the audience, what question was not appropriate, what activity did not really make a lot of sense. So that way you are able to sit and refine your future program based on what you experience in the training program. When you are designing this program, there are a couple of points that will help us in designing this program in a more impactful manner. For example, the first one that I say is the program online or on-site? What difference will it make, if I may ask you? What difference will it make if it's an online program or an on-site program?
I think the online programs, we can be anywhere. So the time, place constraint is not there. Mostly time, of course, yes, but the place constraint is not there. So I think more people can come in as on online programs, but offline, it will be more bonding. How much ever you see virtually like this, as when you come see each other personally, I think the bonding between the people will be much better if it is on site. These are the two main things.
Absolutely.
Yeah.
Absolutely. So like this point, in an online session, you cannot have more than 15 to 20 people. It's not advisable. If you will have a large audience listening to you, they will be just quietly listening and it will be more like monologue from your side. Also, they may get disengaged. They may just have, they will log in, but they may not actually attend your session with great, attention. They will have a lot of distractions around it. So mode of training would actually help you design your program in a manner that will suit your audience, that will make your program, meaningful. Some activities you will have to modify when it comes to the online or on-site program. In the on-site program, as very rightly said by Dr. Aki, that you are able to directly get in touch with your audience. Look at them. They can look at you. From body language, from their non-verbal cues, you get a lot of idea about what they are thinking, feeling, receiving your program. So mode of training has to be kept in mind when you are planning a program. Audience size. A lot of time, you will have audience that's very large. So again, chances are that in such a place, you will be doing more like a webinar or a seminar. Whereas if it's a very small audience, again, there you will have challenge engaging them. Also, creating interest can be a challenge. Activities also will be planned depending upon the small or large size audience. If it's a too large audience, probably you will have to cut down on the activities where people at the back either are not able to participate or they're just not engaged enough to actually enjoy the activity. So these are the things that would impact the outcome. So you will have to plan accordingly so that your audience remains engaged with you. How important it is to know your audience? Why is it important to know your audience?
You can mold your teaching according to that.
The content.
Okay.
Content of teaching.
How much knowledge they have, and they can formulate accordingly.
Absolutely. So if I'm going to address, seasoned people, then I know there's already a baseline information available with them. They already know something. So I have to build on that. And if I'm interacting with a very naive kind of an audience, then probably I have to start from basics. That's one thing. Second is, sometimes people who are knowledgeable they have difficulty sitting as an audience. So you will have to really be mentally ready to engage them in a manner so that they participate, but they don't derail the program and the audience benefits from their learning. So you will have to really strike a balance. With the younger generation, if you will have a session where you are not able to capture their attention, they can actually derail your program. So therefore, it's very important to know who is your audience, what are their age groups, what are their professional backgrounds, which department they are into, what kind of experience they have, because all that will help you to design your program, to suit your audience. And that's very, very helpful. I never used to initially ask this, but a couple of time incidents happen that they said that, okay, we are doing a program for a set of nurses, and I would prepare a session according to the whatever they have told me. Once I reach the site, I get to know, oh, they are not nurses, but they are actually, it's a mixed group. They are nurses, doctors, and quality, personnel. So if you have prepared for a set of audience and then the audience is not exactly the same, suddenly changing your content and examples and pedagogy may not be possible. So it's always good to know who is your audience. If you remember the brief introduction questionnaire that I shared with you was with the idea that I wanted to know you all, your qualification, your department, your years of experience, what is your expectation. If I know this, then it is, I can suit or I can tailor my content and delivery as per your this requirement. Very important to know how willing is the audience. So what is your experience? How willing is the audience normally? Are they willing? Yes or no? What do you say? Are they willing?
First one, they are.
First one there, second one there.
So what about your own experiences? Like if you have been into training, if you have interacted with medical students, if you have interacted with other healthcare professionals, how willing is usually the audience?
I think more than 50% will be non-willing. Even when I was an assistant professor and I was going and taking classes for ophthalmology, and ophthalmology is one subject which even I didn't like as an undergraduate. So that is the first sentence that I told them. Like, I am like man hi man mein, I am thinking about my ophthalmology professors who actually didn't inculcate any kind of interest in me. But I don't want to be like one of them. I want to at least, have some interest, generate some interest in at least 50% of you, so that, you come out as ophthalmologists in the near future. So I feel in an audience, in a group, if you take, I think 50-50. 50 will be interested, 50 will not be.
It depends on the situation, actually. If it is a must or a need for them, they will, because suppose they are coming for an entrance class or a PG entrance NEET exam, many of them will listen to that. But if it is a casual one, not mandatory, and no post test or no, it is not going to affect them, or it is not going to bring anything into for their future, probably they might not listen to that. So need is also a must, a fact.
And also,
post-lunch sessions. Everyone wants to avoid post-lunch.
Yeah. So it becomes difficult to engage them. So they become disinterested. So that means creating interest in your program or in your session also is one of the important tasks. Just do not go with the assumption that people will be very interested to attend. So getting their attention and also creating interest is very important. So therefore, when you design your program, beginning has to be very, very impactful. And normally we say, well begun is half done. If you have been able to engage them right in the beginning, you will be able to sustain their attention. Also, another important point, what is the available or allotted time? This is something where a lot of us still, fail. I remember in certain conferences, they'll say you have only 8 minutes, or you have 7 minutes, or you have 10 minutes, and you actually have to cut down your material to meet that 7 or 8 minutes time. So this is something, it's a deciding factor, how much time you have, and accordingly we need to, design our content. Make sure, and these are some resources I'm sure most of the training places will have, but you need to really ensure that they are functioning. Like for example, sitting arrangement or projector, mic, or video or audio system for projection. Then wall clock so that you can keep an eye on the time and you can, control your content to complete within complete. So usually when I'm taking session, I will always have a wall clock in front of me. Or even when I go for a training, I request them in advance that please have a wall clock facing me so that I can keep an eye on the time. So when you are able to look at the time and I have only this much of time, you can, regulate your content. Having name tags is a wonderful idea. Asking people to have a, sticker or a sticky on their left or right shoulder with only their first name in capital in a size that you can read it from a distance of 10 to 15 feet. That will help you make connection with your audience. If you are able to read their name and call their name, trust me, you will find them more attentive because they know you know their name. I'm really sorry for the bad cough. There are, of course, stationery to note down some points, and then if you are going to do some activities, the props that you need for the activity, and then water facility or some tea, coffee, all that has to be part of this. So you have to make sure that these things are in place. Okay. Couple of tips quickly, and we are going to go in. Sorry?
Electricity.
Oh, yeah, of course, electricity and the backup plan for in case if electricity fails, then you need to have generator in place. Absolutely.
You
So
should
these are
have,
a couple of.
what I realized, one thing is you should have all the photostats or a copy of your slides with you.
Yeah. Not only that, of course, if you are so much used to using slides, I would say slowly become independent of slides. Try to do the program in a more, interactional manner. Of course, slides help us to stay, online, but then reading the content will not help us. So you really need to be ready with the backup plan
Less
in
of
case.
writing and more of pictures and.
Pictures. Yes. Yeah, absolutely, absolutely. So very few slides left, maybe another 5 minutes I will need to cover that. So these are a couple of tips that will help you to design a successful program. The first one is, what is in it for me? You have to integrate this in your program. Right in the beginning, if you want to capture their attention, you have to help them see why they need to attend and how are they going to be benefited personally by attending the program. So you can note down this WIIFM. What is in it for me? They really, if you are able to, like with the medical student, for example, when I do the program, I always tell them that don't look at the program from the narrow vision of working in a government setup where patients are not very demanding. Look at it from the point of view that 5 years down the line, when you will be in your independent practice and you will have patients coming from, educated and well-off background, they will have this expectation from you. And these are the things they will expect. So this is what you need to know. And then they slowly become, interested. Also, some of them want to go for USMLE and for other exams. So there, most of the assessment is on your communication skills, your way of handling your patient. There, these trainings are really very helpful. So if you can integrate what is in it for me, they will actually become very interested in attending. As I said earlier also, beginning and end should be very engaging and very well thought with a very clear carry home message. So we normally say, well, begun is half done. So make sure that you start your session in a very impactful manner. Asking questions is the best way to, have a discussion. And then also you will get more points than actually they are on your mind. And you have seen it a lot of times when I ask you questions, the perspective that you all share sometimes goes beyond the list I have with me. So that's a wonderful idea that will engage them also. Plus, there'll be a lot of it's like more people working on one idea. You'll have more ideas. Then experience has long-lasting impact. So instead of focusing on content, focus on creating experiences. Today, the session I was supposed to take, like I'm at Udaipur, the whole presentation was almost like 60 slides, and I knew it's practically impossible for me to, go through all 60 slides in 1.5 hours and teach them every part of it. It was a pre-planned program, and even the slides were given by the organizers. Can you believe that I showed only one slide? And that was the title of the program. And I did not use any slides at all. And everything I covered through activities and by creating experience. And the audience was very happy. So focus on not using the presentation, but actually having activities where you can make them experience or go through some new learning. So that will have a longer lasting impact. Even studies suggest when you use reading or listening or recalling, you just use a small portion of your brain. Whereas when you engage or when you try different pedagogies, you actually engage, different parts of the brain, which is important for learning. So you have to really be creative in developing your training curriculum and pedagogies. But whatever you speak, make sure that you support your opinion with statements, with studies and report. Because especially if you are dealing with an educated professional class, just making statements will not work. They will not trust you. They will disagree with you. They may argue with you. They may, completely shun away your thoughts. But if you have evidences, if you have some studies to show, if you have some data to show, that kind of quietens them and they start having trust in what you are saying. Very important thing is to keep yourself updated. Your participants can ask you any kind of question. So keep reading, keep learning so that you know more about your subject, much more than your students can ask you. If you have, updated knowledge and skills, your audience will have more trust in you. They'll believe you for being knowledgeable. Regularly time your sessions. A lot of time we err on timings. We over, spill our program. So you have to really be very realistic in how much you can cover and how much you can deliver. Read the feedback carefully because that is where your improvement lies. Every feedback has something to tell you about the way you have delivered. And if they have been honest in giving their feedback, that's the best way to improve your performance. Regularly reflecting on your performance rather than just assuming I did well. Go through every beginning, in between, and you will have an idea that I need to focus on any specific portion of your presentation. Have you heard of the concept of 10,000 hours? Have you heard of this concept of 10,000 hours? So studies suggest that you invest 10,000 hours in anything and you become a master of that trade. So if you want to be a seasoned trainer, if you want to get into clinical communication training, start practicing it, start delivering topics. Maybe to start with, you can do it for your, front desk staff or nursing staff, technicians. And once you get a, hack of doing it, then you can try with other audience also. Because it takes time to refine your content. You'll have to, like you were saying, dry run, or some of you said, I practice at home. Similarly, we can practice with different audience, with smaller size, with audience that's not very demanding or not very aggressive, and they listen to you. That will give you an hand, and that give you a time to practice. So any subject you invest 10,000. These are studies I'm talking about. You spend 10,000 hours, and you can you can be master of that subject. So this is in nutshell about how do you go about designing a program. Any questions about this topic? I can't see anybody actually. I think I would request everyone to have your camera on. I'm not even sure if your camera is on.
Yeah, it's on.
Cameras are on
It's
except
on.
one.
Camera.
So I'm sure there is a network issue at my end, but thankfully at least we could have this session. I was really very skeptical if we'll be able to have this session. It's okay. I understand. It's been, it's almost 10 now. We will have the next topic, and that is facilitation skills. That's in continuation of what we have discussed today. We'll be focusing more on how do you, what are things you keep in mind when you are facilitating the program. We'll talk about this in the next session. I will share the feedback form in the WhatsApp group. I will not hold you further. I will share the feedback form in the WhatsApp group. I request all of you to give your feedback maximum by tomorrow morning, because right now your memories are fresh about the session. So you can give your feedback. By tomorrow morning, you must give your feedback. And then a reminder for reading my book and also writing your reviews in the on Amazon. That will be a great help. Anybody wants to say something? Somebody was
Where to write the reviews? You said in Amazon, your book.
Amazon, yeah. I'll share the link. I'll share the link for Amazon. You can go to the review. There you can see some stars on the right side. If you click on that, it gives you an access to go to the review section. And and you have to just sign in and you have to write your reviews about the book. But read something from the book so that you can write a very authentic review of whatever you think or you feel about the book.
Yeah, I just want to say something.
Sure. Go ahead, please.
How do you rate us as students? How do you think that we can all be good trainers?
Not at time.
I know.
So what I think right now, Dr. Rafi, honestly, considering the enthusiasm that all of you have expressed, the way you all are participating, the way you all are keen to learn, that's very encouraging, if you ask me honestly. Very encouraging. Had you not participated with great interest and enthusiasm, had you not answered questions, had you not come up with ideas that I expect you to share, I would have been slightly skeptical that, is this the right batch? I think all of you are doing wonderful. Taking out time from your busy schedules, and that's a voluntary kind of a work that you're going for. And then late evening, 8 to 10 is not a small thing. I think after a long day, 8 to 10 is a very tiring time of the day and you want to be with your family. But I really feel very nice having you all here and attending the program very well. Regarding your training skills, I think we all begin somewhere. You all must be already into teaching, training, some conference presentations. It's not a rocket science. Anybody can learn.
And you do take care, ma'am. You are having a bad cough, and I think you have to take care, ma'am.
I have tomorrow's full day program at full day. I hope I stay well.
Where are you now, ma'am?
Two sessions.
Thank
To
you.
skip one section, maybe she's suggesting that, and for rest for 2 weeks.
You can go to the lake, Jaipur.
No, I'm not suggesting anything like that. I'm in full joke.
I am such a bad this thing. I do not go anywhere. I just come to my room and then I either work or I sleep. That's what I do. Wherever I go, I normally don't go out. I don't roam around. I'm poor on that front, I can say. I'm poor on that front.
But I think you are constantly breathing communication skills, ma'am. You are constantly, your whole system is full of communication skills. So probably you cannot enjoy anything.
Absolutely.
You must be looking at the Udaipur Palace and still thinking about how to communicate, right?
Right in front of my window, there's a lake. There's a lake right in front of my window.
Communicate. You can communicate with nature.
Yeah, that's true. That's true. For that, I go to Rishikesh. I go for 2-3 days in a year to Rishikesh. That's a beautiful place to visit. I normally go there.
So mental awakening and spiritual.
So I mean, I would also be picking some of you. I would also be picking some of you in my future master trainer program, whom I think that yes, you can really add value. So I would request you to do your presentation with great interest and sincerity. And I mean, if I'm sure all of you are really good at it. I don't want to discriminate, but then maybe some of you will get a chance to become speaker in my future master trainer program. That's what is on the on my plans. But let's see how it goes further. So should we close?
How many days you are spending in India, or like you're based more in US?
No, I'm not based in US. I'm based in India. I'd gone to US visiting my daughter. It so happened that for the last 2-3 years I had to go 2-3 times, and I went and came back. But now I intend staying here for at least 10 years, and then maybe I go for a couple of weeks visiting them. So thank you so much. I will not hold you further. I'll share the feedback form in the WhatsApp group, and I would request you to give your feedback.
Yeah, 1 second. Just one more question. Actually, when you are talking about the presentation part, actually it is not really clear as to what all we are supposed to do. I don't know whether it's only me or I think we need to have a clear-cut idea as to what are you expecting from us regarding the presentation.
So don't worry, Dr. Rakhi, don't worry about that assignment. Next week when we meet, I will be giving you an idea about what exactly you have to do in that presentation. Okay. I'll give you a brief about it. I'll be sharing a document with you, and then you will be discussing with me your presentation, and I'll give you my input on what I expect you to present. And I'm sure you'll all will be able to do. It's not a very big thing. Not a very big thing.
Yeah. And another thing, Dr. Hari Mohan sir, I would listen to your story carefully. Okay, one day. Yeah.
I'm sorry for putting you in that spot, those who were speaking and those who were listening. It was not a good experience, but I had to make you experience that, to value the importance of attentive listening.
This will be
Thank you, everyone.
In your recording, it will be there? The YouTube recording?
Yeah. Yes. No, breakout room recording. No.
Dr. Rakhi, I'm used to it at home.
Sorry, sir?
I'm used to this at home.
That is why sir picked it so fast. And I said, sir, I think you caught me red-handed. I'm like, go away.
Chalo ji. Okay, thank you so much, everyone.
So much. Thank you. Great.
Thank you.
Good night. Good night, everybody.
Good night, everybody. Good night.
Bye-bye.